Thank you very much, Dr. Perez. I hope everyone can hear me. I'll go through a very short, really short session on patient selection for total shoulder replacement. Probably this request to make this presentation is stemming from the fact that I've been interested lately in shoulder surgery, shoulder replacements, and arthroscopy. And so we've gained some experience, and we would like to share it on how we go about selecting patients that we end up replacing. So welcome. I think to begin with, I must say that almost always the times when we need to replace the shoulder, it's an elective procedure. And so it's important for somebody wanting to replace the shoulder to know that the safety of the patient is paramount, because there is no hurry. And when you're talking about the safety of the patient, we mean the skill that will be deployed to replace to do the surgery for the shoulder, plus the anesthesia. And I particularly take keen interest in the anesthesia that is offered for patients who are replacing shoulder, because the patients tend to be in a seated position, beach chair, quite seated. And as you know, this position renders itself to certain challenges like blood circulation in the head. And you twist the neck to the other side if patients have radiculopathies. And so you need an anesthetist who works with you, who knows who is a safe guy, who knows what he is doing, and keeping certain maps. We insist on certain maps during shoulder replacement above 65, so that you don't get strokes. And you need to have prepared your patient to make sure that you don't have this prior ischemic strokes, or the anesthetist takes care of such situations. So safety of surgery is a top priority, because this is usually an elective procedure. The other thing to note is that there is no coercion. Usually the surgeon and the patient must sit and agree really on what is the problem bedeviling the patient, and what is the solution the patient hopes to get, and what really can the surgery that you're trying to choose offer. Because it is important to have what is called limited goal approach. You have to limit your goals when you are offering patients this surgery for the shoulder. You must tell them what they may be able to do and what they may not be able to do. So just before we go into this, I wanted to sort of cascade why, or when do we replace a shoulder? The 3 points illustrated on the screen are really the situations when we end up replacing the shoulder. When the shoulder is painful, and usually the pain will be due to osteoarthritis, or maybe there's some kind of deformation, maybe after a fracture or something, but the shoulder is painfully destroyed, usually osteoarthritis, or it is stiff, and then we offer this patient shoulder replacement. The second indication for shoulder replacement is usually when there is instability. And this instability is what you are not able to solve by, let's say, for example, if you're having instability due to a Bankart tear, then you will offer the patient Bankart. But I'm talking about instability due to severe soft tissue loss. Maybe you've lost the rotator cuff, you have instability, or you've lost bone stock, usually the glenoid, in such a manner that you have severe instability. So unstable tissue loss giving you instability is one of the other situations that we end up replacing. The instability that we may replace, and yet it was maybe, say, a Bankart, is in certain situations when you have, let's say, posterior shoulder dislocation or even anterior shoulder dislocation, that you have lost options. You now don't have options to sort. For example, chronic, let's say 6 months dislocation posterior. Most of the time, functional outcome of attempted repairs of those soft tissue is not as good as when you offer the patient a replacement. So when you have unstable tissue loss, or of either soft or bone nature. Lastly, we will usually offer patients replacements of many kinds, starting from hemi to total to reverse, when they have a terrible fracture. We know that certain fractures of the shoulder, especially type they're called type 2 nears that involve the anatomic neck. They tend to get AVN of the head, or when you have 4-part fractures, AVN of the head you will get when maybe from 3 to 4-part fractures of the proximal humerus. You tend to get AVN maybe up to 25% in 3 parts and up to 75% of AVN in 4-part fractures of the proximal humerus. And so when you have such a severe outcome of AVN that is going to cause the patient pain and stiffness, especially in 4-part fractures, sometimes it is making sense more and more currently to offer the patient a replacement as a first choice, because the functional outcome tends to be superior to attempts to repair. And I'll go through 1 or 2 examples of this situation. What's special about the shoulder? I think it's important to note that we all know the shoulder relies a lot on soft tissue stability, because the shoulder doesn't have a socket like the hip that gives it bony stability. So because of that, the shoulder, especially for the glenoid, offers a very poor site for anchorage of your prosthesis. And so over time, we have evolved methods that are giving us solutions for these challenges. And we will see that we have nearly 10 options that you can offer these patients as you tend, so that a few you will end up selecting for total shoulder replacement. I think we all know that when we get fractures in the proximal part of the humerus or the glenoid, we offer patients ORIF and all forms of pain management that range from really injections to painkillers to physiotherapy to all these forms of ORIF, from normal plates to proximal humerus plates, locking plates, all those things, and even ligament and muscle repairs. And this list sort of gives an idea of the hierarchy of management for proximal shoulder injuries, proximal humerus, injuries, as you go down, getting in maybe complex in terms of what you could offer. I think where we are starting from is around here, maybe resection arthroplasty offered for patients who are maybe not willing to, either they don't want a replacement for some reason, or they have infections that are not getting solved, or they have an implant that has failed. The implants you have offered them have failed. But one must realize that as time has evolved, we have quite solved a few of these so-called failed implants, because we now have different types of shoulders that can nearly solve a lot of these challenges. So before you offer patient resection arthroplasty, which is really sometimes the option, especially in infection, and it's good for pain relief, sometimes it's good to bounce it off people who are doing these shoulders, so that we see if we have other solutions. And then something that is frequently not taught or emphasized is this double osteotomy for patients who are having painful arthritis of the shoulder, especially things like rheumatoid arthritis, or the joint is destroyed. And then one could, as an option, offer them a double osteotomy. In this case, really, to make it simple for people who are not familiar with it, you cause a fracture. You cut out the neck of the glenoid, the neck of the scapula, and you cut out also the neck of the proximal, the surgical neck. And that sort of seems to provide pain relief. And in some, so those who are interested in shoulder, you can check it out, that it's usually one of the options for, not especially for rheumatoid per se, when you have inflammatory, because in inflammatory cases, you already have inflammation. But in cases that are not inflammatory, let's say just arthritis, sometimes when the patient cannot accept arthroplasty, implant, you can do you cause a fracture there, and it is thought, maybe we don't understand, that in the course of healing this fracture, the pain seems to disappear and patients can have reasonably good function. And then for the old timers, we know about the arthrodesis. The arthrodesis patients will tend to be young patients, or so it was taught, younger patients or patients with pain who are not good candidates for joint replacement. But one must realize that if you do an arthrodesis, function might be good and motion might be pretty acceptable, but conversion now from arthrodesis to replacement, should the patient want, might not be as good or as successful, because sometimes you have already caused muscle atrophy by the time you are replacing now or converting. If it will ever be necessary, you might not have as good outcomes. But we must realize that more and more arthrodesis is not being offered as much because of entry into the field of different types of shoulder arthroplasty implants, like reverse shoulder in particular, which has changed, sort of revolutionized the outcome for shoulder replacement. And then we have hemiarthroplasties. Hemis are good, especially for people who have proximal humerus fractures and they have a good glenoid, because you know you don't have to replace what is not spoiled. The patients are young. You can do a hemi. And the hemis offer you quite a good option to reconstruct the rotator cuff around it. We have in this country, for example, been able to do the near hemi implants. In Eldoret, we've been able to do them, and they offer a good function. But one must not offer them to people who have rotator cuff tears that are irreparable, because the hemis will migrate and the patients will get pain after that. You must also note that, as opposed to the hip, for example, in the hip, arthritis of the acetabulum will probably make you not to put a hemi for a fractured neck or femur. You will not put a hemi implant, Austin Moore, Thompson for that matter, because there is arthritis in the socket that the head is going to articulate. But for the shoulder, per se, actually arthritis of the glenoid is not exactly a contraindication for insertion of a hemi near, for example. And the outcomes, especially in terms of pain, are not as bad. But again, because so long as the rotator cuff is good. But of course, the better option for such patients, if one is able to get anchorage for the polyethylene line and liner, you can do an anatomic total shoulder replacement, because as you know, good function is obtained when you have in the anatomic shoulder replacement. We don't want a metal-backed glenoid base implant. We want polyethylene on metal to be on the humerus side. Then, in the event that you have, for years that were, say, 5, 10 years, 20 years ago, as people became frustrated with anatomic shoulder replacement, then we moved on to constrained total shoulder replacement. This is basically to contain especially the humeral head when you have rotator cuff injuries. But now you are all aware that we now have the reverse shoulder replacement, and it's available in this country. And this is what has really solved most of so that the need for constrained total shoulder replacement is much less. How do we go about this? I think in deciding when to replace, we answer several questions. What is the problem of the patient? Most of the time, patients will present because of pain. Maybe they have a fracture, they have stiffness, they have disuse, they are not able to use, the range of motion is limited. And so one must answer, what is the problem of the patient and what does the patient want? As we said, when you're offering the patient whatever type of replacement you will offer for intervention, you need to be aware that it is possible what you will offer may not be what the patient wants. In answering the question, what is the etiology of whatever the patient has, then you are able to establish things, for example, like, let me just give, for example, if you have an infection, that is what is causing cicatrization around the shoulder, and this infection turns out chronic osteomyelitis or TB, you may not consider a joint replacement. I know that in the past it has been taught that you can sort of clean a TB infection and replace a joint, and we do that in the knees and stuff. But those of us who have ended up doing these joints, even the knees and stuff in a TB joint, you know that we have run into problems unless you do a constrained kind of knee. And so in the shoulder, it is still advisable to keep away from these patients who have infections like TB and chronic osteomyelitis unless you have a lot of courage. Now, what is the prognosis with or without surgery? And you need to discuss with the patient, because some of them, the patient might have pain now, but with the management of the pain, you might find that later on the pain seems to lessen or go down, and the patient, maybe that is the aim of the patient. All they want is no pain. And if that is, so you need not offer the patient surgery. So you need to tell a patient, without surgery, this is what will happen to you. And with surgery, this is what is likely. And that can only be done if you understand exactly what a replacement will do to the patient. And then, as I have listed above, and that's why I started with that slide, it offers you the hierarchy of management that you can offer the patient, depending on what problem the patient has. And so understanding the surgical options and the outcomes that are available, and then you might be able, so that you do not offer an anatomic shoulder replacement to a patient who doesn't have rotator cuff. And can they achieve the patient's need? I think I have alluded to that, I have explained that. Once you now consider arthroplasty, so you are considering some form of arthroplasty, a replacement. Now you need to answer certain questions, because let's speak, for example, the muscle tube. It's very important for you to be able to examine the patient that you are considering arthroplasty for the shoulder to confirm the intactness of the rotator cuff. We know you can examine the rotator cuff very easily. You can pick out supraspinatus, you can pick out the subscapularis, you can pick up the teres minor, those muscles around it. You can pick them up, you can pick the activity of the deltoid clinically, but also if you are in doubt and you think that the rotator cuff is worn out, especially in things like chronic dislocations, chronic fractures that have been neglected, or surgery has been done so many times, then you need to confirm using an MRI. And we all know that MRI will tell you very well if the fat infiltration of fibrous changes. Even there are classifications for this. How to here that grade the infiltration of fat. And when you find that more than 50% of the muscle is replaced by fat or fibrous tissue, maybe you shouldn't consider offering that patient an implant that doesn't take care of that, because that rotator cuff function might be poor. How is the bone stock? And in bone stock, we don't routinely do CT scans, but if there have been fractures of, they say, there's scapula, especially the glenoid area, or certain or chronic neglected injuries around the shoulder, chronic dislocations, sometimes the head or the humerus will have got into the proximal scapula or the glenoid area, and you don't have bone stock. So it is wise to do a CT scan, or shall I say it is not unwise to do a CT scan. And because it gives you a very good idea of bone stock, and then you can be able to know, for example, if you are going in for a reverse shoulder replacement because of the chronicity of the problem, and you think the shoulder muscles are not good, you are going for a reverse, you need to attach the glenoid implant onto the remaining part of the scapula. And you find that sometimes you may need to bone graft before you attach, or you may even need to a revision kind of implant, because you have implants that you can anchor on the acromion, anchor on the coracoid process, and then anchor it maybe with a few screws on the remaining part of the body, so that you go in prepared. Is the patient motivated, and can the patient afford? I think I'll expound on this one. Patient motivation is important, because you want a patient who's going to be swinging that arm immediately you replace, unless you have any reasons not to, and cooperate. And if you have a motivated patient, I've seen a patient we replaced, she went back to VOE, and in another 3-4 weeks, she sent us a video. She was already swimming after replacement of shoulder, and I'll show a few of her pictures. And that kind of patient is a very good candidate. But then again, she must be, the patient must be able to afford, because shoulder prosthesis is not cheap. You will find that patient is paying upward of $500,000 to maybe 600. Maybe that is something that we can discuss as to why it is expensive, because the less you will notice that these joints that are not done as commonly, there is not much of competition. So the cost of the implants are still very high, even from source. So, but otherwise, the patient should be able to afford. And then, is the patient too sick? I think I mentioned that these patients who might suffer from this positioning of beach chair position, and you might want to avoid, and the patient is too sick, as infection you don't want to replace, or as immune deficiency. Especially if, for immune deficiency, I'm not talking about HIV. I think some of these teachings are changing now. The pendulum is swinging as we talk. When the patient has immune deficiency, in particular, what is mentioned is lupus. I guess because there is usually ongoing inflammation that now loosens even your implant, and the patient outcomes have not been very good. But we're not talking about immune deficiency like HIV, because I think HIV patients we could be able to replace. I don't have personal experience with HIV replacements for total shoulder, but I know that people have replaced with not so bad functions. But when you have an inflammatory situation that is immune deficient, you have an immune deficiency with an inflammation kind of thing, then it is said those kind of patients will give you loosening, and your outcome and muscles might waste away, and then you don't have very good outcome. So maybe for those patients, as the pendulum swings, maybe these patients are the ones who may benefit from the new reverse shoulder replacements. I've mentioned about chronic osteomyelitis and TB. It is still advised that you keep off replacing these ones. And if the patient is looking for compensation claims, we all know in orthopedics, these compensation claims, you operate the back of a patient and they don't leave your office because they wanted you to fill for them P3s and stuff like that. These are patients you might want to be careful about. And then one of the reasons why we do a good clinical examination is to rule out progressive neuropathic conditions, in this particular case, myelin. If you have a syringomyelia that I think the teaching a few years, maybe 5-10 years when I was just starting to learn about shoulders, was that syringomyelia you don't replace. But I think this thing is shifting, because you might have a syringomyelia whose etiology is well known. Maybe it was some kind of blockage that has been relieved by a neurosurgeon or something. And now there is no progression of loss of power for the upper limb. And in that case, you might consider replacing the shoulder. But you must have examined this patient and you are sure that it's not a progressive form of a neural disease or a neurodegenerative disease. And what is mentioned usually is syringomyelia. And then patients who have psychiatric issues, of course, it will come back to the cooperation that we talked about. So now, once you answer those questions, then you move on to replacement, really. And for you to succeed, you will need to understand the biomechanics of the shoulder so that you are choosing the right implant for your patient, master the correct operative technique, because we have seen, even for us who are doing this shoulder, that sometimes a small thing that you miss can end up with the unstable replacement, and then you have to take back the patient. It is important that you master the correct operative technique and choose the appropriate implant for the patient, depending on the patient's history and examination. You must realize that the shoulder requires a lot of range of motion, and it is almost like you are standing on a seesaw. And the more you achieve range of motion, the more you lose stability. And so as you are choosing which implant to give the patient, you want to answer these two questions. Are you getting a stable replacement with enough range of motion as the patient may require? Up to there, I think that should help you to see, if I will summarize, that the way I approach this thing is age. If you notice, I've not mentioned age per se. But of course, I'm not going to replace, maybe it will be very unlikely that we shall replace a 17, 18-year-old like the girl I'm about to talk about. Generally, this will be a replacement for 40s, 50s, 60s, and 70s. Let's be honest, you cannot be offering this to a Kenyan who is 80 years, because there are a few Kenyans who are reaching that age now. Our life expectancy is 60 years. And a good friend of mine, orthopedic surgeon in this town, Nakuru, asked me, you are 40, you have a destroyed shoulder, and somebody is telling you, let us wait, you suffer pain and stiffness until you reach 60, And yet the life expectancy of a Kenyan is 60, 63 years. So we have to offer these patients a painless, comfortable life when they need it. Because if you offer them when they are 68 or 70 and they are going to die after 10 years, they will have lived most of their life in a painful state. So the worries in the past, I think, when these advisories were made that don't offer replacement to young patients and stuff like that, it was due to the poor outcomes due revisions. When revisions were done, people don't want to revise, they want you to die with that primary joint. But now the techniques to revise and all this, even the techniques for insertion of primary joints has improved. And so this talk of age is becoming less and less in terms of making a decision, because we base our decision on the needs of the patient and the pathology that we have and what kind of can offer the patients currently. So you will see, let's go through some of the examples and how I make a decision. This is a child sent by somebody from very far away in Maralal to me, saying that the father has noticed that the left upper limb of the child is shorter, and that the child is sometimes feeling pain. And they have done, when they noticed this, they also noticed towards the extremes of range of motion, the upper limb on the left performs poorly, less than the right upper limb. So now they said, okay, let's do an x-ray. And they did this x-ray, and you can see that the proximal humerus of this child is not looking very normal. So now this is the question, because I examined this child, and the first thing I asked the child is, what do you want? What do you want? And I realized that they really don't have an answer to this question. It's just that they are wondering why one of the upper limb is shorter than the other one, and maybe they are considering, is it possible to make it equal in length and stuff like that. So I do the measurements. It's not so much. It's something like 5 centimeters, 3 to 5 centimeters, something you might not even be able to pick, because I told them, the child, to put hands on the thighs. As you can see, you can't really notice the difference. So I asked the child to do range of motion. I see that is the elevation we get, forward elevation. And I say, can you eat? And there you can see the child can put food in the mouth. I even asked them to put hands posterior, and the child can literally be able to touch the back. So in this case, why would I operate? I mean, yeah, we can replace the shoulder and give this child a bigger range of motion. Okay, so what? Okay, the child is functioning very well. And so as we said earlier, evaluate what is the problem of the patient and what you are able to offer. Are you really helping the patient? What are the needs of the patient? And the surgeries that we are able to offer now, the patient is not feeling so much pain. Why would we operate this child? So we reassured the child and told them that let us wait. If ever there will be any other problem, arthritis develops, stiffness or something, then we may have on our armamentarium something we can offer to improve. Otherwise, we say this is proximal humerus epiphyseal dysplasia that does not require, and by the way, there was no history of trauma in this child. And so this is probably proximal epiphyseal dysplasia of the humerus. And so we said you can stay like that. There is no problem. Now, the second case is, I hope that you are not able to see the name. I was not able to crop it out. But this is a typical situation that happens in this in our setup. When you're training, you think that proximal humerus fractures are easy to manage until you become a consultant and you realize they're not that easy. Every time you open, you expose very well deltopectoral, you get this thing and the head is down there, you rotate it, you don't know where to put a screw, you end up with this kind of thing. So you can't really blame someone. It is usually a challenging fracture, especially once that head is off. You basically get a coin that you keep on rotating and you're not able to fix it to the right place, even when you have the benefit of CM. And even after you fix it, you find that it is failing. And you can see this patient that I've projected here is actually a patient who was operated 3-4 times by our very senior colleagues. It is not the skill. You find that the operation is failing. The head is still down. And anyway, when you look at this fracture, you see that this is, if barring comminution from the greater, tuberosity, I don't know, but this was maybe one of those type or group 2 near that the anatomic neck is broken and the head is down. This one will give you AVN. And with multiple approaches there, how we will approach this one is we'll start thinking, okay, 3 surgeries have been done. I'm sure there is a lot of fibrosis. I'm sure the rotator cuff has been injured, for so known is fibrosed. And so when we are going in for this kind of patient, we'll probably choose a replacement that is a reverse shoulder prosthesis, because in this case, I am not sure about the position of the situation of the rotator cuff. But if we were, let's say it's a fresh patient, is a younger patient, 50 something, you have done an x-ray, the glenoid looks fine, then if you're thinking to, or if this one, maybe you could put a hemi, you can do a hemi here. But here the need for the patient was pain relief. First of all, she was angry with the many surgeries that had been happened and they were not solving her problem, and pain, and she wanted to be able to swim. And so this is the patient we operated, and she was able to swim. And you can see the intra-op images of the reverse, and we were able to assemble the little bone that was remaining in the proximal humerus, and there it is, the reverse shoulder, and it's looking neat, and the patient was able to swim. Now, you will see that in most of my examples, I have reverse shoulder replacements rather than anatomic shoulder. And one of the reasons why I think reverse shoulder replacement has a greater role in this country, a little bit more than in the West, is that most of our patients will come to you after either multiple surgeries around the shoulder, so they have damaged their rotator cuff, or they have chronic injuries. They have chronic dislocations that have stayed, so the rotator cuff is worn out, or they will persevere with osteoarthritis. And you must bear with me witness that most of our colleagues in the physicians, medical officers, and general surgeons are very quick to inject these shoulders. So even if they have arthritis, they will usually get steroids, multiple steroids. So by the time they come, the shoulders are completely damaged, and really you have a rotator cuff you can't work with. So for this reason, the reverse shoulder has been sort of the workhorse for replacements in our country. But in the West, where people will come very early with pain, maybe the role for anatomic total shoulder replacement is greater. But in this particular case of a young guy who was in his 40s with a proximal humerus fracture and a good glenoid, you can see from that x-ray that he has a fairly good glenoid. This was just trauma, 4-part fracture. I think we elected to use a knee prosthesis, hemi, and this patient is happy with the function of this knee implant. So in a nutshell, what am I saying? Is that listen to the patient. What problem does the patient have? If you allow me to go back to what is the problem? What does the patient want? What is the cause? Exclude progressive neuropathies, exclude infections. And what is the prognosis with or without surgery, and what type of surgery is available that you can offer this patient to solve the problem of the patient? And then remove make sure you rule out the what are they called, these contraindications, psychiatric issues, and immune deficiency and radiation damage. That is, in a nutshell, how I go about selecting patients for shoulder replacement. Thank you very much, Dr. Perez. You can control the remaining part of the discussion.
Thank you, Dr. Lutomia, for the awesome presentation. I'm only seeing 2 remarks. You're able to see them from your chart?
Not yet. Where do I click? I can't see.
Where it's written chart. Yes.
Let me see. You're sharing screen. So shall I unshare my screen first?
You can unshare, then yes. Then next to where share screen is, there is the chart on your left.
I can see mute, security, stop video, pause, new share, pause, annotate, remote. No, there's no chat. More. Let me see more. Chat, yes, I see chat.
Yes. So you have the 2 comments and I think 1 question or something.
Yes, I see from this my colleague Singh.
Yeah.
RSA is now being used in young tumor patients with promising results. However, follow-up is very important. Now, Maybe we haven't, this is very true. And Johan, Singh is Johan, and he has had some experience in India, so he's talking from a point of knowledge about this. And it is true that the reverse total shoulder replacement has sort of really improved what we can now offer patients. If you excise a proximal humerus tumor, you have options to cement a proximal humerus replacement implant. And if you have cut out the rotator cuffs, you can, at the top of your assembly, put a reverse shoulder, and have it as a very stable shoulder, or you have the option of putting a head on it and using a constrained implant. But the functional outcome, when especially the rotator cuff has been removed because of the tumor, and is better when you use a reverse shoulder. Actually, the point to get is that it is now the in thing for challenges, revisions, and proximal humor losses for proximal humerus losses because of tumors. So that comment is true. Now I see the poll. There's a poll running which has now
the poll will continue, but it won't block your chat. Do you mind pulling down your screen?
Oh yeah, I've done it. Okay, thank you, Doc. You know, now I've realized I'm getting old. Now, there is a comment from Wanjiku: for failed fixation of proximal humerus fractures, how does one decide between revision and arthroplasty, especially in patients without osteoarthritis? What are the considerations for patients with tumors? I think we've discussed the tumor thing. For patients with tumors, if you're able to excise the tumor well, and you have your insertions for the rotator cuffs intact, you can assemble the insertions of the rotator cuff on a near hemiarthroplasty if your glenoid is good. If you run into problems with instability, you can use a constrained prosthesis, total shoulder replacement constrained, or you can use a reverse shoulder replacement, which would be my first choice if I have lost the rotator cuff. But one must realize most of these implants are actually coming with slots for you to repair those rotator cuffs. So if you have a rotator cuff tear, injury that is repairable, you could still repair it on these implants. But in terms of functional outcome, reverse shoulder has superior outcomes. Now, to come back to the first part of the question, for failed fixation, how do you decide to go back or to fix it again? Or I think if you're having a 4-part fracture, offer the patient a replacement rather than repeated ORIF. If you have done your ORIF and you can see clearly you are headed for AVN, offer the patient a replacement rather than a repeat ORIF. But if it is a fracture, proximal humerus neck, surgical neck and stuff like that, and maybe just the fixation failed for some reason, maybe you just need to change the implant to a locked plate or something, and then you can decide to, but again, you must know that if you went in there and you destroyed inadvertently, maybe you lost the rotator cuff, maybe it is time to start considering other things. I don't know whether that answers Wanjiku very well. What is the rehabilitation program for this patient postoperatively? I have a very simple rehabilitation program after joint replacement. I notice that when I come to a center and I replace and go away, the colleagues I leave in the center are a bit afraid to rehabilitate this patient. And then you find 2-3 weeks down the line, the patient is still hanging an arm sling or something like that. Especially when we have done a reverse shoulder. Because I use a cemented implant I usually we have the option of a non-cemented implant on the humerus, but I often use the cemented stem. Because that is what I do, this joint is stable in theater. And as I've always said in meetings when I attend, if the joint has a problem intra-op, don't think that soft tissue healing is going to help you. That joint is going to have a problem post-operatively. So you should have sorted all the problems of the patient. Unless you had a fracture, for example, that is making you fear rehabilitation, you want the fracture to heal. You must realize that the shoulder, immobilizing the shoulder any more than 3 weeks is already trouble. And so we want this shoulder moving. That is why we replaced anyway. So my rehabilitation program is very quick. Within the following day after surgery, the patient is pendulum swinging. Within the week, the patient has started, forward elevation, backward elevation. As pain of surgery subsides, which is really the only pain the patient will feel, As that pain subsides, the patient actively elevates and forward flexes the arm. And you will find that by 3 weeks, as I told you, the lady from Voi, and there's, I hope one of these doctor, I think Mubarak, knows this lady, and she was able to swim within a month. So that is how fast it can actually go. I see here, what are the cost implications? Okay, I will tell you the implant I'm using costs 350,000 Kenya shillings. The implant alone. So that is quite steep, and I know that there are other areas. This is a French implant. It's a very high quality reverse shoulder replacement. The knee prosthesis, I think, is available in Eldoret. I do not know how much it costs, but it is not cheap either. So it is possible that Irene, there's something you're doing on the screen, or is it Paris? So that is the cost. The other questions I'm not able to answer because now I can't see them, unless somebody wants to talk.
You are able to see them from
now
your
I am. Yes, now I am. Somebody had done something. Okay, quickly, because we need to end this. There is a comment. When do you decide to go for scapular replacement? I have never needed to go for scapular replacement. Do you give RSA a chance with damaged glenoid? Yes. I mentioned this and said that if the glenoid is damaged, you can bone graft it from the bone you cut off the humerus. You can also use a special implant that is designed to be anchored on the acromion and coracoid process and the glenoid body in the event that you do not have enough glenoid bone stock. Amzak, thank you for good prep. Before patient is operated, do you include relative during discussion? Well, luckily the relatives have already been there during the consultation, and I've explained to them what they expect. And we have been lucky that of all the shoulders we've done, we've had a problem and had to go back for only one of them. All the rest are doing fine. And this one we had to go in because, and I think I remember I presented in the core meeting, we discovered that the subscapularis, as much as they say that without the rotator cuff, you can survive with the reverse, we realized that the subscapularis is a very important stabilizer. And so we've changed our approaches for patients who don't have a very good subscapularis so that we do not harm that muscle. Do you assess the function of the deltoid? Yes, absolutely. Before considering a reverse, we have to assess the function of the deltoid, and that brings in the issue of an MRI cervical spine and even ruling out syringomyelia. Especially patients who have done multiple surgeries, and some people might have pushed a nail through the deltoid. You know, we have these nails and then there's fibrosis. You must check that the deltoid function is good. But take note that deltoid wasting may not necessarily mean deltoid dysfunction. And as the experience in Eldoret will tell you, we've had colleagues in Eldoret with patients who look like they actually don't have a deltoid. But when you ask them to contract the deltoid, you see that it's contracting. If you have that activity, offer the patient a reverse. They'll do good. But when it is paralyzed, then you will not benefit from a reverse shoulder replacement. In trauma, when do you choose? I note the thanks by Dr. Samuel Wanjara. Thank you very much. In trauma, when do you choose TSR instead of HEMI? I think that the point here is to offer HEMI so long as you have a rotator cuff that you can reconstruct, and your, as I said, glenoid bone stock is fairly good. If you have a good glenoid, even if it is arthritic, and the patient is not able to afford a total, even if the glenoid is arthritic, but the bone stock is good, it's not, you know, you're not going to have eccentric loading, and your rotator cuff is good, you can offer the patient a HEMI, and evidence has shown that the function is good irrespective of the arthritic glenoid. It's not the same as a hip, where you cannot offer a HEMI when the acetabulum is arthritic. But if the patient is 60, 70, in my case, I'll offer reverse, or I'll offer total anatomic total shoulder replacement, because in that case, I know that I do not want to revise this patient. I want to offer a total solution that I'm not coming back. What is the lifespan of the prosthesis? I must say, so far, we've had about 15, 20 years of lifespan for reverse. anatomic shoulders have been around for a little bit longer. They are doing 15 into 20s. We are not yet very good at saying how long a reverse can last, but it is as good as at least 10, 15 years from the history from Europe where it started. Any comments on reverse plus latissimus? I thought this would come up. So you know your deltoid is gone. And this is something that I must say that we need to, not much studies are out yet, but I thought somebody will think about it. Your deltoid is gone, you do a latissimus, now you have abduction, and now why should you not put a reverse? I think it would be a good thing for us to try in future. What I would personally try is put a latissimus, have someone do the latissimus, see how much abduction the patient gets. If I'm happy with that abduction, and that was the only problem with the patient, now there's pain, I would offer the patient a reverse. But I must say that this is an area that is not yet conclusively studied. Issue of hemi is the resorption of bone, if not well done. That is true from Dr. Vadgama. Another thing that happens with the hemi, you know, people put the hemi, you reconstruct those rotator cuffs, and then, you know, it starts migrating. Because after you've reconstructed the rotator cuff somehow, it's sort of you have injured it during the surgery, and you start finding that the hemi is migrating. You find an eccentric hemi when you do x-rays 4 or 5 years down the line. And now you have to send the patient to us for a reverse. Is hemi, okay, thanks, Mark. Ondari, thank you, very practical, yes, yes. I think we are done.